Hi, welcome to the NIH online mobile health training course. I'm Bonnie Spring. I'm director of the Center for Behavior and Health at Northwestern University. I'm a clinical health psychologist, and I'm going to be talking to you today about changing behavior and how you might think about doing that in a mobile health environment. So this is what I'd like to cover. I'd like to talk a little bit about why you would think about using mobile health tools to change behavior. Then we'll talk about some basic principles of behavior change. I'll call it Behavior Change 101. I'll talk about some of the changes that are going on in mHealth technology that I think have a really good spillover effect on what we do in behavioral interventions, especially things that we're learning from computer science and engineering about how to re-engineer interventions until we get them right, until they're optimized. All of this, I think, is helping us to learn faster whether the interventions or the treatments we do work. And along the way, I'll use some examples, some case studies in behavior change to talk about who should be on the bus, who should be on your team, what kinds of toys and skills they bring to help us get the job done, and then the very interesting challenges of how do we work together, how do we understand each other and play nicely in the sandbox. So a lot of the examples I'll talk about have to do with treating obesity, which is a major, major public health problem, not only here in the U.S., but internationally. In the U.S. now, a little bit more than a third of us are obese. 2/3 of us are either overweight or obese. If we think about this at an international level, there are 300 million obese people, 1 billion who are either overweight or obese, a very prevalent problem. And a problem that is felt at many levels, not only in terms of our healthcare costs, the medical costs of treating obesity-related disease in the U.S. Are more than $100 billion. But it's not only the health-related costs that take a toll. Actually, the even larger burden falls on the employer, who bears almost $3 billion in costs related to obesity-related absences from work. The costs of what we call presenteeism and turnover. The presenteeism is the sort of dead at your desk phenomenon. You're there, but you're sort of not engaged and productive. Those run 3 to 4 times higher. So this is a problem that is very expensive, burdensome, something we should try to address. So some very basic things about obesity. Many of you will know this already, but just to make sure we start with a common base. In order to manage weight, you need to regulate energy balance, which is very straightforwardly the balance of the number of calories that you're taking in. And the way we do that is through eating relative to the number of calories that we're expending. Most of how we burn off calories is through metabolism. We also burn off a little bit through physical activity. As most of us know only too well, there's an energy balance asymmetry. It's an awful lot easier to take in excess calories than it is to expend them. If you look at how many minutes you need to work on a treadmill to burn off an ice cream cone, that will become immediately apparent. When we think about the way we're taking in calories, we take them in through foods, and the real problems here are the energy-dense foods. These are foods that supply many calories per unit of volume. They tend to be things that are high in fat, in sugar. Alcoholic beverages are another really high-calorie constituent. And the way we need to deal with these is to either reduce portion size or to just eliminate them from our diet. There are other things that we can eat to fill up on. that are less energy dense. They provide less calories per unit volume. Things like fibrous vegetables or fruits. These are great because they're filling and they supply very few calories per unit volume if you prepare them without frying them, adding a lot of fat or sugar. When it comes to the energy expenditure side of the equation, we're talking about activity. Most of the public health guidelines for using physical activity to manage weight have focused on what we call MVPA, moderate to vigorous physical activity. And this is the kind of activity that makes you sweat. You can talk if you're doing it, but probably not sing. And for weight loss, the recommendation is to get 60 minutes per day. For just healthy living, it's 30 minutes per day. But the relatively recent discovery is that it's perfectly possible to be what's called an active couch potato, meaning you can get an hour a day of moderate to vigorous physical activity. You can go to the gym and sweat up a storm. But if you then spend the rest of your time sitting on the couch, which a lot of people do, that's not good for you either, because it turns out that there are unhealthy metabolic effects of too much sitting. So this is a new dimension to our public health behavioral recommendations. So now, when we're talking about healthy lifestyle modifications, we want people to not only be watching what they're eating and to be eating not too much calories, not too much fat, a good balance of fruits and vegetables. We want them to be getting moderate, vigorous physical activity, and we also want them not to be sitting too much. And there aren't too many Americans that do all of those things right. So this is what gets us to the need to have some way of helping people change behavior. So how do we do this? If you're a physician, most people who come to see you in your office will have some behavioral problem someplace in this arena. So what are you going to do about it? Well, the first thing that we usually do is we do education. We're all familiar with education. We all went to school. So what do we do when we're educating? Well, we provide people with information and knowledge. That's a beginning, but it's also not so simple. Knowledge, especially about nutrition, is really, really complicated. It turns out that only about 1.5% of the population meets nutrition guidelines, partly because they're very complicated, they're very demanding, and most of us don't have a PhD in nutrition. There are other things that are challenging. So if I tell you, if you're a couch potato and I tell you to go get 60 minutes of moderate, vigorous physical activity, how do you know when you're doing it? If you're a couch potato, this is not a state that you're in often. So how do you know when you're there? It's very hard. This is a place where sensors that we'll talk about come in very handy. And the bottom line is what those of us who've worked in behavior change for a long time have learned is that knowledge is often necessary to change behavior, but it's very rarely sufficient on its own. It doesn't cut it just on its own. So there's been a lot of many, many years of work to develop theories and approaches to actually change behavior. The theory, the behavioral science theory that is the most widely used today is a theory called social cognitive theory. And basically, it's a theory that says that if you want somebody to change a behavior, they need to have an expectation that if they change the behavior, it's going to work for them, it's going to do something good. And they need to have a sense of self-efficacy. They need to believe that they can do it. The underused part of behavior change theories is something that's covered in a new kind of theory called dual process theory. dual process theory suggests that there's really two different kinds of behavior change mechanisms. One kind is the kind that is deliberate, it's conscious, it's effortful, we make choices. But there's another kind of behavior change mechanism that is different. It's automatically triggered behaviors, things that are going on out of habit. We're not choosing to do them. So to talk a little bit, to unpack that a little bit more, when we think about the behavior change techniques that we usually use to go about changing behavior, we rely heavily on these type 2 mechanisms. Most of our theories about behavior change were developed by college professors, and it shows. We think about you should set a goal, you should self-monitor how you're doing relative to the goal, you need feedback about how you're doing, you need to solve the problem of overcoming the barriers. It's very hard work. These are burdensome, conscious, effortful strategies. There's a whole other set of mechanisms that have to do with processes like stimulus control, conditioning, cues, defaults, environmental prompts, things that drive our behavior without our having to get involved and make the energy to self-regulate. We underutilize those, and mHealth gives us an ability to bring those into play more than we've been doing, and it's an exciting ability. So we get to ask the question, are we in our intervention strategies doing things too much the hard way? Is there a way to do them easier? And what do I mean by that? What are some examples? Well, we start with the fact that when we look at the risk behaviors that most of us have, they don't come just one at a time. They come bundled, they come clustered. So if you look here, a very large amount of the population gets no moderate, vigorous physical activity. A reasonable proportion of the population gets no vegetables daily. A few more of us get no fruit daily. And almost everybody eats too much saturated fat. These are not rare behaviors. These are almost the American way of life, the American lifestyle. So is there a way that we can take advantage of that so that when we're making the effort to change one behavior, we have some other behaviors that are stuck to the target behavior and might come along for the ride as a freebie? How do I mean that? Well, here are data from a study that we did in which we recruited people that had these 4 very common unhealthy lifestyle behaviors. So they didn't eat enough fruits and vegetables, they had a diet too high in saturated fat, they didn't get an hour a day of moderate vigorous physical activity, and they spent more than 2 hours a day basically watching television. So everybody had all those problems. We assumed that it was going to be too overwhelming to try to change all 4 of those things at once. So the question we posed is, okay, which 2, one eating and one activity, could we get people to change that would bring along a tag-along carryover effect, a freebie that would be stuck to the other 2 behaviors so that if we could get those 2 to change, it would come along for the ride in a healthy direction without requiring added burden and effort. As it turned out, our 2 behaviors that worked the best were having people increase their healthy eating, increase their fruits and vegetable intake, and cut down their unhealthy eating, their unhealthy activity to cut down their sitting time. And what you see here in the first part of this graph is the green line shows you what people did with their fruit and vegetable intake. So they started eating just 1 fruit and vegetable per day, pretty typical. What we did was we had them use a mobile health app to just track their what they were eating and their physical activity, and they got feedback about how they were doing. When we started this, there was a real question in our mind about whether people could change these behaviors. If you are a primary care physician and you are always telling your patients to go out and make these changes, usually they come back and they say, I can't, it's too hard. The literature on changing fruit and vegetable intake usually shows if you can get a one fruit and vegetable change, this is really a very major progress. To get people to go from 1 to the guideline of 5, we weren't so sure we could do it. But what we did was we had people uploading their data to a coach. We told them, okay, get half of the way there in the first week, and then get the rest of the way there in the next 2 weeks and maintain it. And what you see is people were able to do this in 3 weeks. They got the first leg of the way there in a week. Then they got the rest of the way there in another 2 weeks. They went up to 5.5 fruits and vegetables. With the sedentary time, they cut down their screen time. They went from almost 3.5 hours of TV watching to about an hour and a half. So that was the first good news. They were able to do it. And then what we did was we said, well, that's great. We actually paid them some money also to accomplish these things. And then we said, of course, we're thrilled that you've made these changes. We hope you'll keep it up. But you no longer need to keep it up in order to get the financial incentive. All you need to do is every month send us a week of data just so we can check on how you're doing. And what you see is that people did fall back a bit. They dropped down a bit in terms of these healthy behaviors, but they maintained a quite impressive 1 standard deviation change for 6 months, just on their own. So they started at 1 fruit and vegetable. They wound up at 3. Whopping change compared to what we usually see in the literature. They went from 3.5 hours of TV watching to 2, and they kept it up for 6 months for no particularly good reason. Why did they do this? There are 2 parts of this finding that I think illustrate type 1 automatic processes. One is what you see here. We didn't ask people to change their saturated fat intake, but they did. They made an untargeted, come along for the ride, complementary change in their saturated fat intake. They went from about 12.3% saturated fat to under 10%. Nobody asked them to do that. Why did they do that? 2 reasons. One, that when they were eating more fibrous fruits and vegetables, they were fuller, and so it helped to crowd out the fat without them having to think about it. It turned out that the more pressing, the more compelling aspect of the mechanism was that they stopped snacking when they were watching TV, because they were watching less TV. So they were doing less self-administration of junk food. They didn't have to think about that. They didn't have to intentionally deprive themselves. They just weren't watching TV. So the paired, cued behavior that comes along with watching TV, the hand-to-mouth snacking just went away. The other aspect of this that I think illustrates a type 1, non-effortful, non-burdensome change is the habit mechanism. Why did they do this? Why did they maintain this behavior for out to 6 months? Well, once they had done it, they said, well, I made this change. I did this good thing for myself. I might as well keep it up. It became not burdensome because it had become habit. When we compared the different ways of getting people to change their behavior, and we looked at what gave them the biggest bang for the buck in terms of healthy lifestyle behaviors, in terms of trying to change a couple but get a tag-along benefit. What you're seeing here is this is the composite healthy lifestyle score. So higher is better. When people did the intervention I've just described, so they increased their fruits and vegetables, cut down their sedentary behavior. That's the green line on the top. They made this very large change that led to a persistent large effect size, continued for 6 months. Our hypothesis, this is what we had hypothesized because of this mechanism of optimal substitution, that they're substituting fruits and vegetables for saturated fat, and they have this complementary change. They cut down their TV, so they're cutting down their saturated fat. Our prediction was confirmed there, but we really didn't know what to predict about other kinds of behavioral regimens that might work well. So you might predict that the thing that people would be able to do the best because they have the most practice at it is traditional dieting behavior. So you might predict that what somebody should do the best at is increasing their physical activity and cutting down their saturated fat. Most of us have been on a diet at some point. So maybe that would be the thing that would sort of free up spare capacity and let you make other healthy changes that come along for the ride. But what you see here is that's the red line. That was our familiarity hypothesis prediction, and it was flat out wrong. That was really hard for people to do when they had to make the traditional dieting changes. They were unable to bring along anything else for the ride. That was hard work. It led to the least improvement. And so that we learned something about how to harness an unintentional, unburdensome, non-effortful health behavior change. So taking that line of thinking a little bit further, when we think about how to go about pursuing health behavior changes, one of our issues is we think we know how to do that. And we think it has to be very hard work, very intensive. And I think it's time for us to just wonder whether some of our assumptions about how we have to make behavior changes, how we have to intervene to produce them, whether these may be what's getting us into trouble. So let's take the example of how do we produce weight loss? We know how to produce weight loss. Ask any behavioral psychologist how you do this. It's intensive lifestyle intervention. That's our gold standard. We have wonderful data showing that we can produce and sustain weight loss. We've established it in the Diabetes Prevention Program intervention and Look Ahead. These are interventions where essentially you give somebody a goal of achieving about 7% weight loss, and they need to do it by cutting down their calorie intake and increasing their physical activity to about an hour a day. And we have wonderful outcome data that this will not only produce weight loss, it will improve metabolic and clinical outcomes, like it will help prevent the conversion to diabetes in people who are pre-diabetic, and it will help to manage the condition. So we know how to do it. However, the problem is that it takes us somewhere between 16 to 24, sometimes as much as 36 in-person sessions. The patient has to come to see the interventionist for 90-minute sessions between 16 and 36 times. It's great that we can do it, but particularly in this economy, there's some thought that this is just, it's just too expensive and too burdensome for it really to be scalable. Trouble is that we know that if you try to cut back on the treatment intensity, you lose the benefits. So, and this has been just well established. Pretty much when you get to under 12 in-person sessions, you're not going to get the weight loss. So here we are with a very burdensome treatment that works, but it's burdensome. So the question that mHealth enables us to ask is, could there be some way that we could reduce the intensity of our behavioral interventions, but maintain their effectiveness for weight loss or other behavior change outcomes by using technology to help us optimize the efficiency of the treatments? And this is the door, the window of opportunity that mobile health technologies let us walk through. And there is an interesting parallel here. If you think about what has happened with the evolution of technology, and of course these are evolutions that have not been driven by behavioral scientists, they've been driven by engineers and computer scientists, but behavioral scientists are learning from them now. If you look at the black relay racks, this was how computers worked when I was in graduate school. These were these relay racks that the people in the animal lab had. The experiments were run by these paper tape programs that ran the computers, that in turn ran the experiments, so a human didn't have to do it. Well, eventually, those of us who did human research got our own computers. We got these gigantic IBM machines around 1980. And these things, they used the punch cards. They weighed about 2 tons. They cost more than $1 million. And they let you get a mighty 20 gigabytes of memory. Now fast forward to 2010, and now you can get one of these little micro SD cards that gives you 32 gigabytes of memory, and it costs maybe $125. So something has changed very, very dramatically in my lifetime, and similar changes you can expect to happen in your lifetime. So why? What has this been all about? Well, these changes have been made possible by something that we refer to as Moore's Law. Moore was the co-founder of Intel, and he observed that that for at least 50 years, and we expect it to go on for at least 20 to 30 years more, every 2 years, the number of transistors that it's possible to fit on an integrated circuit has doubled. What that means is that with smaller and smaller technologies, you get a doubling of memory, of processing speed, of capability, basically. And so the way that this is translated is, take a look at the phone on the left. This is what we now refer to jokingly as a brick phone. I remember when these first came out, they were massive phones that had really pretty terrible quality, sound quality, but they worked, all the way down to now look at the very tiny little smartphones, cell phones that we can all carry. That's due to what we've learned to do, how we've learned to optimize technology to make it more efficient. Now we can wonder about, it's not only phones that have had this kind of change. Look at what's happened to the size of our television sets. Remember the big bulky things that we used to use. Now we use flat screens. We can joke about whether this is really forward evolution or whether it just illustrates the principle of the conservation of mass. As the TVs have gotten smaller, the people have gotten bigger. But the principle still holds that devices are getting smaller. The really fruitful learning for us in the behavioral sciences is, as we have started to incorporate these optimized technologies into our intervention, Some of the carryover for us is we get to learn from the modes of thinking, the modes of doing science, the modes of progressing that are used in engineering and computer science to learn how to optimize our interventions. So what do I mean by this? Well, our tradition in behavioral science has been when we're going to do a behavioral intervention, it's very expensive to put together a clinical trial. If you're going to have to see people a whole bunch of times and it's going to cost a whole lot to run this trial, the thing you want to make sure is you're going to get an effect. So how have we tended to do that? We throw everything into the kitchen sink. We want to make sure that people are going to make a change. So we give them at least 16 in-person sessions, preferably with other people so they're getting social support. We make sure that they're self-monitoring their behavior. We have them write everything down that they're eating and all their activity. We may call them up on the telephone and give them coaching in addition. We may throw in text messaging and we may tailor it. We throw in financial incentives because if we're going to finally get the resources to do a clinical trial, we want to make this work. The trouble is, so we have things that work, but they're not exactly very efficient. We can learn from engineering and computer science how to go back now and optimize our treatments to make them more efficient, to make them more scalable. And so what I'm depicting here on this slide is the progression from this kitchen sink approach down to an optimization approach that gets leaner and meaner. And there are several different research designs that have been adapted by Linda Collins and her group from the Methodology Center at Penn State and others at University of Michigan to apply these methodologic approaches to the development of behavior change interventions. I'll just briefly touch on them here because you're going to have another lecture on them. One, which is nicknamed MOST, the multi-phase optimization strategy, is one where it's basically a screening experiment that we apply to all these different intervention components to figure out which ones are active, and to get them as potent as possible so that your initial starting intervention is optimized so it is the one that is most likely to produce a maximum behavior change in the average person that you're studying. So the opt-in acronym actually refers to an obesity trial that I have in the field now with Linda Collins, in which the question that we're asking is, what intervention components can we use to produce the maximum weight loss and maintenance that I can get for $500? So I'm optimizing for a criterion of efficiency. I know that I'm probably not going to have an insurer who's willing to pay more than $500 for weight loss treatment. How can I package my components into an intervention bundle that will efficiently produce that effect? SMART is a great set of designs that takes the next step. It deals with the fact that no matter what the treatment is, it can be the most effective treatment in the world, not everybody is going to respond. There is no pill, no medication treatment, no surgery, no nothing that everybody responds to. There will be response heterogeneity. SMART is a research design strategy for tackling that heterogeneity. It poses questions like, what should be the first intervention? Where should I start? What should be my initial treatment strategy? How long should I wait to see if it's working? How long should I wait to see if there's non-response? And then it asks questions like, okay, if there's non-response, what should be my next strategy? Should I switch strategies? Should I increase dosage? Should I wait longer to give the person more time? And what emerges from SMART is a set of algorithms about a treatment strategy over time that addresses the fact that it's not going to be the same thing that works for everybody. The really exciting cutting edge is the JEDI. And this acknowledges the reality that what works for each individual is likely to be highly personalized. This is a way to develop just-in-time adaptive interventions that learn what is working for an individual over time as a function of their changing context and their changing state. These are interventions, a strategy for developing interventions that are evolving and adapting in real time, depending on what you as an individual are doing. Very exciting stuff. We would be nowhere in this space if we had not had the opportunity to learn from another discipline, to learn from computer science and engineering, how they optimize their technologies, which we're now using similar approaches to optimize interventions. So just remembering the big picture question, so why is it that we're bothering with mobile health interventions? We're bothering because this is a way that we can increase our population reach, the scalability of our interventions, and improve maintenance. We no longer have to only be restricted to interventions that require us to see somebody in person for a minimum of 16 in-person sessions. They have to drive to us. It takes them a lot of time. There's the expense of parking. There are many, many logistical barriers. When we're using mobile health technologies, we can actually send these technologies out into the field with people. We can take the intervention with them and reach them in their own environment. These interventions also help us, particularly in behavioral science, with the issue of intervention fidelity. You know, when we're doing a medication treatment, we package the pill, we do quality assurance on the pill. We know that the person, if they take the pill, is getting what we intended them to get. When we're doing behavioral interventions, we're doing interventions that are delivered by individuals who are very variable. And it can be hard to know whether people are getting the intervention that we intended them to get. When an intervention is being delivered by a technology, if the technology is working, they are getting what the intervention was programmed to be. So this is also a help for us as behavioral scientists. Another thing that mobile health interventions do is that they give people, they're very engaging. They give people feedback. It's not that you only go once a week to see your dietitian or to see your therapist and they give you feedback then. They're getting feedback in real time on these mobile devices. They can get it in the moment. They can get, they don't have to wait till they see the therapist at the end of the week. If they need help, it can be there on their mobile device. And they can be connected to experts, to coaches, to their primary care doc. The mobile health facilitates that kind of connected health. And the most important aspect I've been emphasizing is the potential efficiencies, the learning that we get from computer science and engineering about how to be more efficient, learning how to optimize. So the core technique in most behavior change interventions is a technique called self-monitoring. And the notion is if you want to change a behavior, you need to track what you're doing. It's not going to happen by magic if nobody's paying attention. The way that this maps onto technologies that help people self-monitor is through a mechanism that is a control system, or there's actually a psychological theory called control systems theory. And it's pretty basic. Carver and Shire developed this theory quite a while ago. And the notion is if you want to change a behavior, you basically need to know two things. You need to know where are you now, so you need to be able to perceive your behavior, and where you're trying to get. What's the goal? You need to see if those two things are discrepant. You need to compare them. That's the function of the comparator in this model. You see if they're discrepant. If they're discrepant, you change the behavior to try to produce a match. So this is a model that came out of the physical sciences, and it's elegant as applied to the physical sciences. So take an example like when you have a flat tire, You can see that it's flat. You have a goal, you know what it's supposed to look like, and you just keep pumping air into the tire until there's no discrepancy, and then you're done. The challenge comes in when we move into the behavior change arena, and things get a little more complicated. So now take the case where you have a goal of eating a 500-calorie lunch. So how do you do that? Well, you have to compare what your current situation is. So here's the lunch that's in front of you. And you try to compare them. Do they match? Is that 500 calories? Well, it's sort of close. It probably depends on the condiments that are under that bun, on whether there's mayo under there or whatever. But it's not hit you between the eyes apparent like a flat tire is. So people need help with doing that kind of comparison. And this is what mobile health technologies help us do. So here are the ones that I was working with when we first started in this space. Many of you will probably be too young to remember the Palm Pilot and its lovely green screen. And what people did was that we asked people to enter what they were eating, and it gave them feedback about where they were relative to their goals. So you remember the multiple behavior change study I presented to you before. So this was a scenario in which somebody was trying to increase their fruits and vegetables. They could see from that thermometer that they have a goal of getting 5. And that they're part of the way there. They have a goal of getting an hour of physical activity, and they're part of the way there. So that device is converting what their behavior is, their eating and activity behavior, into something that they can compare easily to a goal. It wasn't so easy to do these studies back then. We had to have the data hot sync to a computer, if you imagine the number of different kinds of computer desktop systems that there are in the city of Chicago, you can imagine the joys of going to do house calls to get the technology to work. But the way that this technology was working was it was illustrating a bunch of very well-established behavior change principles. Goal setting, self-monitoring, giving somebody feedback, and then the really important one, the connective health aspect of this. The data were being synced and going to a person who was monitoring, who was supporting, and holding the person accountable. And these coaches usually were not in contact with somebody very much. But if you were a participant and you stopped logging your data and you stopped tracking what you were eating, you knew you were going to hear from the coach. So the coaches actually would spend maybe 5 minutes on the phone with somebody every week initially, then every other week, once a month. But the participants knew that someone was hovering, supportively holding them accountable. So this was a connective system that let us accomplish that. The demographics of the people in our early studies was they were pretty well educated. They were fairly young. They were in their mid-30s, so they were probably reasonably technology literate. A question that we had was, this technology was, even though it's Palm Pilots, it seems very dated to us, it was really cutting edge and a little bit scary at the time, particularly for older people. So we wanted to see if we got folks who were a little bit less technology literate, who were a little bit older, would they benefit? And so the next study that we did was with a population of veterans who were enrolled in the VA's weight loss program, a program called MOVE. When we did our focus groups to prepare for this study, we interviewed lots and lots of veterans, and at that time, not one of them had used a Palm Pilot. This was just a very unfamiliar technology. So what we did was we wanted to see if we added this technology, this technology connective system, to a program that was already in place at the VA, a group treatment for obesity. So people were going to weekly group meetings where they would cover diet and physical activity and behavior change principles. Would this technology help them as compared to just recording on paper and pencil? And the important thing here that you can see from the demographic characteristics is that these folks were, this was a different demographic. These folks were in their late 50s, many of them over 60. And we were delighted to see that really with just this difference in whether they were recording on paper and pencil or recording on technology, the blue line is showing you the folks recording on the technology, and they got a significantly greater weight loss than those who were doing the recording on paper and pencil, and it lasted for a year. This is actually the slide that I find the even more informative. So what we wanted to know is if you, did it make a difference if you were adherent to attending your main weight loss groups? So we called people adherent if they went to at least 80% of their in-person treatment sessions. And what you see from the red lines, the solid line is those people who were adherent, went to 80%. Dotted line is those who didn't. And what you see is that it didn't, for the folks who were recording on paper and pencil, didn't matter if they went or not, they didn't lose any weight. But look at what happened to the folks who were using the technology. The dark blue line, the solid blue line shows if they both used the technology and went to 80% of their treatment groups, they lost a substantial amount of weight. They lost about 15 pounds and kept it off for a year. But if they didn't go to the treatment groups, if they just had the technology and didn't go get the added treatment, they didn't benefit. This, to me, is the demonstration that it's not the technology in and of itself that does the magic. The widget doesn't do the magic. You need to combine it with the other behavior change principles that we know work. You need to go get the knowledge about nutrition. You need to get the knowledge about how to change your physical activity behavior. You need the social support. The widget in and of itself, the technology alone, is not going to do the magic. So as we've moved along, I think I'm happy to show you that we no longer use green screen Palm Pilots. We now use both Android and iPhone smartphone apps. And I want to tell you just a bit about how we have learned to develop these. So, and much of this has had to do with how I have learned to work with people from different disciplines, really foreign to my own background in psychology, to learn from what they know and to benefit in terms of intervention design. So what you see here is, it illustrates the process that we went through to develop our next generation of apps. I now worked with people who were experts in design and human-computer interaction. And so what they do is they develop prototypes of these apps, and they take them around and get people's feedback on them. And what you see on the left is a prototype that was, it's not a Palm Pilot, but it's pretty much using the same graphic display that I was using on the Palm Pilot. Look at the bottom one. It shows you the intuition of trying to fill up that thermometer. The person is trying to push up their activity to fill in the whole blank space. That's very intuitive. People can get that. Now look at the top thermometer. That's the one that is now depicting your calorie allowance. And the problem is that top bar is anything but intuitive. If the intuition is you're trying to push that thermometer up to fill up the bar, that's exactly what we don't want you to do. We don't want you to make weight or make your calorie allowance. We want you to cut back on it. So it wasn't until I was working with human-computer interaction design folks that I realized we'd had a terrible design interface. What we needed to do was to find something equally intuitive and familiar, but not a thermometer to depict the feedback about calorie and fat intake. And what these designers helped us to do was to develop a new graphic display that showed us we could keep the same thermometer for physical activity feedback. And what you see here is we have an accelerometer that is Bluetoothing back the physical activity information that's populating that nice green thermometer that shows activity. But for helping people to accomplish the diabetes prevention program, we want them to be tracking their calories and their fat grams. So there are two fans or dials on the top, one showing calories, one showing fat grams, and they're color-coded. So they're green when you're in the zone where you got a fair number of calories left for the day. They get yellow or gold when you're getting close to the edge, and they get red when you've surpassed it. So people love this app, and they really like these displays. Works for them, very intuitive. We also wanted to try to find a way to bring in the social aspect of effective behavior change onto the app somehow. So our first thought was, well, we would treat people in teams, we would want them to compete. And this is partly our development team was a very high-achieving group of people. And you can see the first approach that we were going to take. We were going to have a sort of a metric that showed the teams symbolized by an alligator and a rooster to see who was making faster progress, who was winning this race. But when we took this prototype out to talk with the people that we wanted to treat, they said, this doesn't really work for me. I'm somebody that I'll do a 5K race for charity, but I don't care about winning a race for me as a person or winning a game of tennis. So what this showed us was that we didn't want a purely competitive motivator. We wanted something that was more cooperative, but on the other hand, there were other people who liked the competition. So we devolved to a system that we call co-opetition. And what this meant was that the groups competed with each other, but they got information about how the other members of their team were doing. What you're seeing here is they're getting information about the degree to which their team members are tracking their food intake or wearing their accelerometers, and they're being motivated to support each other for the common good of winning the weight loss competition. How do you learn how to put together a system like this? Well, you really can't do this on your own. So what you're seeing here is the group that we worked with to assemble the application you just saw. And there are behavioral scientists, psychologists, there are nutritionists, the data manager, and two very important people, Tom McTavish, who's the fellow standing up in the blue shirt, who used to be the head of cell phone design at Motorola, and our brilliant Hal Snyder, who is a physician, computer science programmer, and because we could never pay him what he was worth, he's now a chief systems architect at Orbitz. We all had to work together to figure out how to put together that app. Well, as you might imagine, this is not always simple, and sometimes it's hard because it's just hard working with people. It's sometimes easier just to charge ahead on your own. But it's also hard because we come from these very different disciplines. We don't speak the same languages. This is the language that Hal Snyder speaks. I don't speak that language, and yet somehow we have to be able to communicate well enough to get the job done. So I want to end by spending a few minutes talking about the importance of interdisciplinary team science, some of the challenges, to show you some of the resources that might help you work through this, because this is just really work you cannot do on your own, and the field needs these different disciplines to collaborate. So I've already mentioned the issue of communication. There are different languages. We have different mental models about how we approach science. There are different role relationships, almost different cultures. For example, in the medical culture, the culture is very hierarchical. There are early morning meetings. People dress professionally and formally. In the computer science world, people dress very casually. The meetings may be later. They're more democratic. Everybody has an opinion. You bring these two cultures together in a meeting, you can just imagine what an interesting translational process happens. But even more fundamentally, underlying some of these cultural differences are real differences in epistemologies, in viewpoints about how you know things. There are differences in methods from the very first, very most basic issues about sample size. In the study I just described to you, Tom McTavish, who is our design expert, had a budget for research. And it had a sample size that I considered the absolute minimum for a behavioral study. I think it was 20 or 30 people. Well, when they do qualitative work in design, they look to achieve saturation, consensus on what the interpretation is. They tell me they can do that with 7 or 10 people, and there's no point in continuing to recruit the rest of the sample because they've reached saturation. This just is a very different way of thinking about sampling than an experimental psychologist would use. There are different views about theoretical and conceptual models. And even a real one that you encounter very early on is the different views about data analytics. This is really important. So there's a profound difference in the way that experimentally trained folks and computer scientists and engineers go about data analytics. Those of us in the behavioral science arena tend to work in the manner that we frame a hypothesis, we collect data, we analyze the data to see if it confirms the hypotheses. If it does, we say we know something. If not, we go back and we reframe the hypotheses, collect new data, test whether it confirms the hypotheses, and so forth. In the arena of big data analytics, they do things differently. They collect their data, mine it to develop hypotheses, express the hypotheses as algorithms, and consider that a form of knowledge, and use that to predict what will occur next. From the two different perspectives, if you are a classically trained, biostatistically oriented person, you will see the big data analytic approach as fishing, data dredging, not very complimentary terms, not building a generalizable base of scientific knowledge, rather building a knowledge base or algorithms that apply to a very specific context, maybe even down to an individual, personal context. But you don't see it as building the broad base of scientific knowledge. By the same token, if you're a big data analytic person, very often there are views about biostatistical approaches and biostatisticians that can be quite negative. Because statisticians are using techniques that are developed, many of them making assumptions about data distribution, assuming that things are usually based on the normal curve, you may have some misgivings about what statisticians do. You may see them as sort of push-button technicians who just push a button on a computer program. You may see them as sort of the police in the medical arena. Statisticians are often seen as observing. They're sort of the gatekeepers on studies that are being submitted for example, FDA trials. And so these views there's not been an awful lot of crosstalk. There's a lot of misunderstanding, and yet we need to put them together. There are great advantages to being able to learn on the fly through data mining, to develop algorithms that are tailored for the person. We need to bring these constituencies together so that they can collaborate, learn to value the skills and toys that the others bring into the sandbox, and benefit to improve our interventions. Often it's not easy. It can be very frustrating. Even just discussions about what's a model. Here, what's being depicted is a computer scientist, an engineer who is banging his head against the wall about the theories that we behavioral science people want to use. We have to somehow have a way of measuring perceived susceptibility or outcome expectancies. They just want a mathematical formula that tells you, does something predict something else? And it seems like this is all sort of verbal mumbo jumbo that just gets in the way. They want to just collect the data, figure out if they can predict, and worry later about what's the mechanism that's going on. It's a very different approach. Together, they give us a really wonderful complement. At odds with each other, they just generate a lot of confusion and conflict. It goes further when you're trying to collaborate on an interdisciplinary team. There are challenges that come up with knowledge dissemination. Basic things like, what journals are you going to publish in? Is it science, nature, PNAS, and that's basically it? Or do you want to go to Journal of Consulting and Clinical, or Annals, or Translational Behavioral Medicine? Do you want to go to a specialty journal? Or do you want to go to a broad journal that appeals to multiple disciplines? There are different conventions about publishing. For behavioral scientists, you don't get credit for your scientific work until it appears in a journal that can be cited. If you are a computer scientist, what matters is your convention presentations. For behavioral scientists, we do a lot of those, and they don't get, they're sort of seen as a trial balloon. They're not given great credence. If you are a computer scientist, the convention presentations are very tightly peer-reviewed. They might take only 2%, and they're published at the time of the conference, and they would never then be published again in a journal because the knowledge base moves so fast that why would you want to wait? The technology would have moved beyond that point by the time the publication lag played its way out. I've already talked about the value of theory. Sacred to behavioral scientists, just a barrier, an obstacle to many computer scientists, engineers. Other conventions about authorship in the academic arts and sciences community, a tradition is the first author is the dissertation student, second author is the mentor. In medical communities, first and last authorship are the two high-status positions. And very, very different views about how to tabulate publication credit. Some resources quickly that might help you as you start to move into this space. One is a set of online learning modules that my group and I developed called Coalesce, or the website is teamscience.net. Here you see the review of these in JAMA because they were developed for the CTSAs, the Clinical Translational Science Awards. What these do is you have to sign up. It's a login membership, but you don't have to pay anything. And they have interviews and references with the people who are actually working on the science of how to do team science productively. There are 3 different modules, one for people in the behavioral sciences, one for folks in clinical, and one for basic scientists. and pitched for different levels, for a junior investigator, for a senior investigator, or for a research development officer at a university whose job it is to try to bring together collaborative teams. Here's another resource. The National Cancer Institute has a terrific repository called the Team Science Toolkit. You can search for many, many different resources. And one that I particularly want to call your attention to was actually developed by the ombuds people at the National Institutes of Health. Howard Gadlin, with his colleagues Michelle Bennett and Samantha Levine Finley, published a book on collaboration in team science. And it has, when I call out a particularly useful feature of it, it has what they call a prenup for scientists. They say the only people more foolish and romantically oblivious than people in love are scientists. They tend, at the start of a collaboration, just not to realize all of the things that could be challenging to work out along the way. And their basic premise is, you can work out almost anything, but it helps if you think about it ahead of time and discuss it and formalize it so you've got something to fall back on and renegotiate if you encounter difficulties. So to conclude, I think it's a very exciting time. I envy those of you who are just starting out in this area because I think you're going to see tremendous progress. I think mobile health tools can really help us a great deal in the behavioral arena. They can support behavior change interventions. They help us to remove access barriers, to get people help at the time and the context when they need it. They increase our ability to reach into the population that needs help, and they're very engaging, much more engaging than just talking with a person can be. I think we've had a lot of worry about the digital divide, and I think much of this has been fueled by our starting with technology-supported interventions that were simply delivered over the web and required a high-speed internet connection. I think these digital divides can be overcome very straightforwardly by mobile health technologies, which have actually penetrated into underserved and low and middle income countries more rapidly than into the affluent. But also just, I want to just reiterate my experience that even working with very low technology literacy populations, you can overcome almost any kind of a barrier if you're prepared to just spend time with people, training them, and be available in a friendly way, a non-intimidating way by phone or by email or whatever for when they have difficulty. This is really not a problem. Anybody can use these technologies. I want to highlight it's not the widgets themselves that do the magic. These technologies give us another channel to deliver and activate behavior change mechanisms. They engage people, they help them do their self-monitoring, their goal setting, they give them feedback, they give them reinforcement, they can give them support and accountability, help them with problem solving, and they can be a form of connected health. They can help connect people with coaches, with health professionals, with family who can provide support when it's needed. I want to suggest that our intervention science has up to this point made excessive use of our type 2, slow, deliberative, high-burden processes. They're a lot of work. And one of the great advantages of mobile technologies are because we've got them with us all the time, because they can serve as a cue and a prompt, as a way of bringing your social network to bear, as a way of creating a context around you that can trigger behaviors automatically, effortlessly. This is the frontier in terms of catalyzing type 1 behavior change processes, where I think mobile health technologies have the greatest potential to pay off for us. Another thing that I think has been a terrific side effect, a benefit of our sort of intermarriage between behavioral scientists and technologists is we have learned that we don't just have to use our heavily burdensome interventions the way they've always been. We too can learn to optimize our interventions just like the engineers and the computer scientists have learned to optimize their technologies. This is really exciting stuff. In order to get there, we need a context where the different disciplines, particularly the behavioral scientists, the computer scientists, the engineers, but also the graphic artists, the artists who know how to inspire and motivate. We need a forum where these folks can communicate and thrive. And I want to conclude by pointing you to this quote by Buckminster Fuller that I think just really says it all. If you're in a shipwreck and all the boats are gone, a piano top that's buoyant enough to keep you afloat may come along and make a fortuitous life preserver. That's not to say, though, that the best way to design a life preserver is in the form of a piano top. I think we're clinging to a great many piano tops as we accept the way that we did things yesterday to be the only means for solving a given problem. We can do better, and I think mobile health interventions are going to help us do better. So thank you very much for your attention.